So what convinced me that this might reflect the adverse effect is that it matches this age-related temporal pattern that was consistent with the vaccine rollout. So older age groups got the vaccines in the first few months of 2021. That's where you see these significant beta weights for those age groups. And then you see positive significant beta weights in the second half of the year when in the younger age groups, when they started getting more vaccinations. So that is sort of an interesting pattern that fell out of the analysis.
Welcome back, everyone. Today we are very excited to be joined from New York City, I believe, Professor Spiro Pantazatos. He's an assistant professor of clinical neurobiology at Columbia University. And he is going to be presenting a recent work that he has published as a preprint. Yeah, it's out there. It's waiting to go through peer review, but we want to dig into it. So it's called the risk-benefit ratio analysis of COVID vaccination stratified by age. And so we're going to let you present and bug you with questions throughout, if that's okay. Please. Thank you for coming.
Please. Thank you for having me. So the title of the preprint is at the bottom here on this slide, which is COVID vaccination and age stratified all-cause mortality risk. And then the title of the talk is I'll tie in that paper with a sort of a simple risk-benefit ratio analysis of COVID vaccination stratified by age. So in order to do that cost-benefit analysis, you need to have accurate estimates of the risks. Plenty of research discusses the benefits, but this research is trying to fill a gap in terms of trying to compare the actual risk to do that type of analysis. So I'll be discussing first some work from my collaborator who is responsible for all of the European and Israeli data analysis, Irving, and then I'll discuss my analyses that I contributed to this. So the idea is to use, just to give a general overview, this uses publicly available data to cross-correlate or relate vaccination rates across states or countries with mortality estimates in order to first test if there's associations that can be detected using that type of data, and then use those data to derive data-driven estimates of mortality risk that you can then use for this risk-benefit ratio analysis. Oops. Yeah. So to give a little bit of background, in terms of the benefits, this was a recent paper that came out as a real-world study from Israel that showed about 90% reduced mortality in COVID deaths from people who received the booster relative to people who didn't receive the booster. And this paper was actually, the authors, to their credit, were really clear about some of the limitations of their study, which include potential sources of bias, including potentially higher COVID risk in the non-booster group that accounted for these effects. So we're not clear what portion of this 90% reduced relative risk is actually attributed to the booster versus some pre-existing bias between the groups that could have affected their results. More importantly, this study, this is the animation that I was talking about. It's not that great, but more importantly, this study, they're up front and they say, they don't have any safety data. They're not, so they're publishing just on the effects, the benefits, and they don't provide any safety data. Usually with a clinical trial, you have safety assessments, and that comes with the sort of standard. And these boosters, they're a little different. We don't know how different are they from the original vaccine doses. So it's important to have that data. So in my opinion, it was a little, from their point of view, they might have felt like it was important to publish about the boosters. But at the same time, it seems like they could have had access to this type of data, and and that they maybe should have tried to include some of that with the publication.
So just quickly, we got
Go ahead.
a rough idea. I mean, I haven't read this paper, but
Yeah.
when you say they're assessing the safety, does this mean they're just tracking statistics over people in the wild with two different treatment regimes, not like a controlled randomized
Exactly.
lab?
Yeah,
Okay.
it's in the wild. Exactly. So they're taking hospital records in this case, and they're matching. They're taking, and they're exactly. It's not a controlled.
And sorry, and what do you mean by safety data? Do you mean just like
So
things
safety
other than
data, things like adverse events. So what's the rate
Okay.
of people in the booster group? How many had an adverse event, like non-COVID related adverse event?
So they looked at death just in both groups, basically.
They only looked at COVID death. So that's my issue with the papers. They had the data. They could look at all-cause mortality. They could look at any deaths and see what percentage, what percentage of the people in the booster group died from other causes, which they didn't report. So that would be the most important sort of data you'd need to compare. All right. Yeah, go ahead.
So they compared people that died from COVID unvaccinated or unboosted versus
2 doses. Unboosted.
Okay,
so in this case,
So 2 doses, did you die from COVID? And no doses, did you die from COVID?
No, 2 doses, did you die from COVID? 3 doses, did you die from COVID?
I see. Okay.
And this paper, and this paper is just focusing on the booster. So that's the thing. They only looked at COVID. They didn't look at other types of mortality, which you'd want to do to assess the risk, or it's one of the outcomes that you'd want in order to assess the risk, and that'll be the focus of this talk. So then the CDC, generally that's where you go when you want to find out more about the vaccines. They do report on adverse events. And in this case, the most recognized adverse event is myocarditis, especially in younger males. So that event on this page, unfortunately, they don't cite like quantitative studies or any percentage risk of experiencing the event. And of the people that do come down with carditis, like how severe is it? Like what percentage are not able to, for example, return to their normal activities? So those are important quantifications that you need in order to back up the claim, like they do here, that the benefits, that the benefits far outweigh the potential risks. And the only sort of, they qualify it and say that the adverse reactions are rare, but again, there's no actual numbers that you can attach to it.
Is that because they don't have that data, or they haven't gotten to an analysis? Or
so there is data that they have published. I mean, pericarditis is probably the most published risky event from the vaccines. So there is data. So I thought it was unfortunate that they didn't include some citations to those studies. They do that with the allergic reaction, so anaphylaxis, which is a common side effect to vaccines. They do cite studies that report the risk, like what's your percentage risk of having anaphylaxis after vaccination. Now, these studies are based on the Vaccine Adverse Event Reporting System, VAERS, which is a passive reporting system. So it basically accepts reports of adverse events. Usually your healthcare provider is required to report an adverse event, regardless of whether they think the vaccine caused it. So these events, they take, they calculate, essentially, they take the number of reported events and divide it by the number of doses that were administered up until that time to estimate a risk rate. Now with death, they do report a number. So using VAERS, they take the number of VAERS reported deaths, which is 10,000 in this case, reports. These are just reports. Divide that by the number of doses that were administered up to that point, and they get a number 0.0022%. And they do stress the limitation. The limitation of this approach is that these aren't verified to be caused by the vaccine. So it's just an adverse event that happens after the vaccine. They don't really do follow-ups as much to like autopsies or to confirm. So that's one limitation. The other limitation, too, as well, is that this is known to suffer from under-ascertainment bias. So especially for mild symptoms. So people have like a mild reaction or even moderate. It takes effort to actually report it. So most of those don't get reported. So you're missing a lot of these events just because you're relying on the healthcare provider or the person who suffered the event to report, which they don't always do.
And
So
is that biased towards mild outcomes? I guess there's a DAP you're more likely to report.
Yeah.
Okay.
So there's data to show that this 1% is really, I think, just for all sort of types of reactions, and that's not, as you'll see as I get later in the talk, the more severe reactions are more likely to be reported. Yeah. So that's so the other main method. Well, actually, before I get to that, I was going to mention. Yeah. So what the CDC didn't cite was this paper that came out in March earlier in the year, where they did do a more active surveillance approach, specifically with anaphylaxis. So they actually followed up with people actively to see if they experienced anaphylaxis following the vaccination. So they looked at about, I think it was like 60,000 employees at a healthcare system. And there they were able to confirm that a rate of 2.5 per 10,000 vaccinations. And they note that this rate is larger than the rate that was reported in these papers based on VAERS. So these papers here is basically the source of these numbers right here. So if you compare 2.5 per 10,000, you divide that by these rates, those rates are anywhere between 22 to 98 times larger. So that's right there suggesting that it's consistent with what you'd expect with under-ascertainment bias from VAERS, and it's also suggesting that the actual risk estimates are larger, like an order of magnitude at least larger than what's currently being acknowledged or circulated.
And I guess there's also a background rate, no? That you should subtract from this?
With this, with the VAERS, there's a background rate that you'd have to worry about. With this study, there's no background rate. It's just like people that come down with it versus not, and then you just take the whole incidence rate. Go ahead.
Sorry, you're comparing? I guess I'm a bit. So you're comparing 0.025 per 10,000 to.
Yeah. So this is a rate of 0.025 per 10,000 based on these papers, based on VAERS.
Okay, these are based on VAERS. Okay.
Yeah, based on VAERS. Yeah, and I think I'd have to double check this, but I think they were just comparing. I think these are different because they were looking at Moderna versus Pfizer.
I see. I see.
So I think that's why they report those two numbers.
Okay.
Mm-hmm. So the second approach for vaccine safety data and surveillance is the vaccine safety data link, and this uses electronic medical records from like 7 institutions, provider organizations, where they match hospital codes. People, when they get vaccinated, and then they see prospectively if they had an adverse reaction based on hospital codes, and then they use that to estimate an incidence rate for different types of adverse events. The main limitation with these studies, though, is that if you go to their website, you'll see that they don't, there's probably has to do with patient health information, protecting patient health information, but you're still limited in terms of the actual data that you can analyze from a previously published VSD study. So they only provide a final data set and not earlier versions. So the data provenance is limited in those types of studies. So I would say that's at least one limitation. All right, so getting back to, no, this is a different paper. So yeah, so this paper in early September was one of the first studies, studies based on the VSD to look at risk for adverse events after vaccination. And this study, they looked at 23 different types of common adverse events after vaccination, which I'll go into a little bit more. And this study, unfortunately, is not that informative because their main comparison was comparing risk rates in two windows in vaccinated people, both in vaccinated people. So they're comparing the probability of an adverse event from 1 to 21 days post-vaccination versus 22 to 42 days post-vaccination. Now, the problem with this is that 42 days is actually the accepted risk window for most adverse events following vaccination. So if something bad's going to happen to you, most likely it's going to happen within those first 6 weeks after you get vaccinated. And so they're taking two windows that are both within this risk window and comparing them to each other. And you're not going to detect a safety signal if the risk is equal in both windows. So the assumption is that the risk is higher from days 1 to 20, from the first day to the 21st day, but they don't support it. That's actually not supported. If you look into the literature, you actually see that the true risk windows are cited at 42 days. And in this case, this method actually suggests an even longer window for a certain type of event, in this case, a clotting disorder following the MMR vaccine in children. So that's a problem with that study. Now they do include an analysis where they compare the risk in vaccinated versus unvaccinated, an unvaccinated comparator group. Yeah, go ahead.
Sorry, Spiro, just to clarify for myself, the acronym MMR is the same as mRNA vaccination?
That's the
mumps. Okay, sorry.
Yeah. This was a 2009 study.
Okay.
Sorry, I wasn't clear. Yeah. Mm-hmm.
Thank you.
So they do, interestingly, in the supplement, they include an unvaccinated comparator group. And here they do find the known risk. They do find evidence, they find the numbers that you would expect for myocarditis. So if you look at the table, here, this table, supplementary table 6, they show this adjusted rate ratio, which is basically, you can think of it as a ratio of two probabilities. The first probability is the probability of an adverse event in the vaccinated group, and the denominator is the probability of the event in the unvaccinated group. So any numbers higher than 1 is risk in the vaccinated group. Numbers lower than 1 is risk in the unvaccinated group. So that the interesting thing about this table is it's showing significant effects, even stronger than the myocarditis, in these other events here, having to do with thrombosis and heart issues. And you see, these p-values, low p-values, and they don't report. The authors, basically, the only thing they mention about these events is that it is consistent with their primary analysis in the vaccinated group. So interestingly, these events have been associated with vaccination. So through case reports. So if I went to PubMed, and you can find here, I'm just showing 7 case reports of these specific types of events following the vaccination. And if you go to VAERS, even with its limitations, raw numbers are not that helpful, but in VAERS, you still see some evidence for an association between these specific events and vaccination if you type in these terms. Yeah, go ahead.
If we just go back to the previous slide, I was seeing some values below 1 for a few of them. Like, does that mean that in the unvaccinated group, in the vaccinated group, it was a lower risk for everything except for myocarditis, pericarditis?
Exactly.
Okay.
Exactly. Right. Yep. I should color code this table to kind of make it easier. But yeah, that's exactly the interpretation, is that it seems that this table is strongly suggesting that the vaccination is protective against the very adverse events that have been previously associated with vaccination.
And that's controlling for the protection that it confers for COVID. I assume some of these things are.
So yeah, these are non-COVID. These are events. So yeah, I have to look at this paper specifically to see if they specifically exclude COVID related events. The next paper that I'll show does exclude. Yeah, so this is all trying to, these are supposed to be effects that are independent of COVID.
Okay.
They're just trying to isolate the effects of the vaccine itself. So COVID is, yeah. And this next paper, which is the equivalent of this paper, and it's based on the same data set, but they just look at death. That's their main outcome, which is this paper right here. So even in the title, they're letting people know that they're looking at non-COVID mortality risk. So here, consistent with this previous paper, they're reporting significantly reduced risk of non-COVID-19 mortality in the vaccinated versus the unvaccinated. So the unvaccinated are dying more often in this time period window. And the authors suggest, sorry. So this is not something you would expect. If there was no effect, if there's no risk, I'm sorry, to put it in other words, you wouldn't expect the protective effect of the vaccine against non-COVID mortality. You would expect it protects against COVID, but not against non-COVID mortality. So the author suggests, which is somewhat reasonable suggestion, that maybe these lower rates have to do with inherently different behaviors in people who choose to get vaccinated versus not. So maybe this is reflecting fewer risk behaviors or healthier. This is speculation. There's no data that they go into other than to suggest that future analyses should address these issues.
I think maybe you'll get into this. But
yeah, go ahead.
Could it be somehow controlled by looking at a time window? You
That's
imagine lifestyle is okay, it sort of remains constant, right?
That's what they do, yeah. So they control for the amount of time that they observe each person. That's factored into the.
Okay, interesting.
But yeah, so this, yeah, go ahead.
Oh, sorry, I didn't mean to cut you off, but just to be sure, COVID, I'm not 100% sure, but I know it can cause in some cases myocarditis, for example. Is that true?
True.
Okay. Can it cause any of these other side effects?
Okay, I won't say true. I'll just say, I've heard,
okay.
Yeah, we can accept that as a premise.
Can we also, is it possible that I don't know anything about this, but can it also cause any of the other side effects? Or is there any evidence out there available showing that it can cause like thrombosis or any of these other?
Especially in the beginning, I will say, yes. Yeah, that there's higher risk of those events with earlier variants of the virus. Yeah, thankfully not so much with the latest variant. But
okay. So when we say that, so could it just be that the protection that we're saying is just protecting you from COVID and keeping you from dying from or having an adverse effect from this thrombosis or myocarditis?
Yeah, so that assumes, So if this paper was not successful in excluding COVID deaths from the outcomes, that would be a flaw in this paper. If that did explain these findings, then that would mean that the paper did not successfully exclude COVID related deaths, and that they're missing, that these deaths are really being caused by COVID.
Right. But how do you exclude, like, so I'm assuming that the cause of death would be thrombosis, for example, or myocarditis. When they exclude it as a COVID death, is it that you died from myocarditis but had COVID? Is that how you exclude it, or?
Wait.
I guess my question is. Yeah. So my question is, how do you determine what a COVID death is?
Yeah. Well, with this paper, if I remember correctly, what they did was they matched whether someone had a COVID test it's like 60 days prior to the event. So if there was any evidence for a positive test 60 days or up to maybe 90 days, I forget the time window,
Right.
then they excluded it.
Okay, so it's really like they're qualifying a COVID death as someone that died that could have had COVID potentially.
Yeah, COVID associated. So they're careful and they used COVID associated death because they didn't want to have to deal with whether COVID caused the death or whether
Right.
the person
Okay.
died with COVID. So they were safe and they just excluded
Okay.
anybody that had any positive evidence for having COVID within 60 days of their death. They just excluded it from the analysis. So it's possible that they missed, if there's some latent effects, but it's not the first sort of interpretation of, if we were to take this paper at face value
Right.
and assume that they were, for the most part, just looking at non-COVID death. I mean, lots of things cause death. Then if we were to take this at face value, then their conclusion is perplexing because it's not something the vaccines were made for, that they're protecting against other types of death.
Is it fair to say that for the group where we have no known COVID association, that we're not missing some positive COVID cases because there's some underreporting? Or I'm assuming in hospitals nowadays, everyone's getting tested, right? So
that's the thing is, for cases, I would say there's definitely underreporting for cases. Now, whether for death, I would say I would need to see evidence that there's underreporting or that they're missing COVID deaths. If anything, maybe they're over counting COVID deaths given how they counted. So I would have to, I think in hospital situation, of course, people could be dying at home. So that's the question, is like what percentage of these died in the hospital versus at home where you can't ascertain, or you're not likely to call those a COVID death.
Or a myocarditis death, I imagine, right? I mean, if you're dying at home, you're not probably reporting that very carefully. But.
Yeah. So those are all questions. So this paper, to me, it raised a lot more questions and answered them, especially with these findings. And one possibility could be, given that these adverse events that this other paper looked at was based on the same data set, one possibility is that maybe this happens to me all the time when I analyze data, there's like some mislabeling of the groups, inadvertent human error, and the group labels were switched. We don't know because you can't really access previous versions of the data set to really dig into it to see if that's a possible explanation.
But are current versions available?
You can get the final data set. Yeah, you can get the final data set. You have to apply. You have to come up with what your analysis is. You basically like a small grant just to get access to the data, and you have to get your IRB to approve it. So they make you go through these loops. I mean, probably because this is electronic medical record data, they don't want to just share it with anybody. So I can see the reasons for that. But yeah, it does make it less likely that other researchers are going to work with the same data set. And that just limits your transparency of the findings.
And is there a reason you think that the myocarditis number is going the right way or the way we expect it to go?
That makes sense. The myocarditis makes sense. They find that in their data, was that the
I guess I'm asking like if the labels were switched.
Yeah.
I guess the hypothesis would be that they were switched for everything except the myocarditis.
Yeah, exactly. So that so the assumption or the speculation would be that they could be switched just for some of the events, but not for the others. If that's, because that would make sense. If those results, to me, given the research, the papers that I've been seeing, that would sort of make more, that would be more face validity. So with this background, which the point is to show that there's still gaps in research, and really, to me, I'm a very hands-on data scientist. I don't trust data if I can't access it directly and work with it. So this is where I was intrigued by some Hervé Seligman, who's on ResearchGate, and he puts up lots of reports. He studies mostly vaccine, both benefits and adverse reactions. But in this case, he was looking at publicly available data, cross-correlating mortality across 20 or so European countries with percent vaccinations. So just correlating those two variables as a function of lag, as I'll get into that. So for example, in this plot, he's just showing that there's a positive or adverse relationship between percent vaccinations, for example, during the week 12 of 2021 with z-scored mortality in week 14 of 2021. So that would be like a lag of 2, a correlation that falls under a lag of 2. And in this example, he's showing a negative correlation, which is presumably a protective effect. So the more vaccinated, the lower the mortality. In this case, between week 13 of 2021 with week 21 of 2021. So in this case, there's a lag of 8 weeks between vaccination and mortality. So as you can imagine, you'd have lots of these plots for one lag. You would have, since January, he's been doing this since January. But you can imagine there's about 30, you'd have about 30 different correlations that all fall under a certain lag, in this case of 8. And the same for all other lags. So when you take those correlations and you stack them on top of each other, and you're just plotting on the y-axis the percent of positive correlation. So you only care about the sign of the correlation. You get this type of plot, where he's showing the percent of positive associations between the first dose and mortality as a function of lag in weeks since the first injection. So this bottom axis is the number of weeks since you got your first dose. And this y-axis is, how many of those correlations are positive, basically. So what you see, and this just sort of falls out of the data, this very interesting pattern, which maps with what is known about when the protective effects of the vaccine kick in, which is around 5 or 6 weeks after you get your first dose, and also when is the highest risk period, which is the first 6 weeks after you get your vaccination. So you see this adverse event, this adverse period here that goes up to about 5 weeks, 6 weeks. Yeah, go ahead.
And is this, so are these time separated comparisons done across the year? So it doesn't matter when the first, it's relative just to within the delta, right?
Exactly.
Doesn't matter,
Yeah,
I'm guessing this is controlling for seasonal effects or something like that.
It's not actually. Yeah.
Okay.
So there's a lot of confounds, potential confounds. This is a very simple graph, but I think it's still powerful, but it's not controlling for seasonal effects. Yeah. So that's a limitation. You're just stacking up. You don't care where you are in the year. You're just stacking up those correlations to get an estimate of, yeah, well, I guess it's more for power, or it's more for, yeah, I think it's more to just get, yeah, go ahead. Yeah, raise the hand.
I think you just didn't.
I forgot to lower.
Yeah.
My bad.
Oh, you forgot to take it.
I don't know why I
Sorry,
do that.
I thought you had a quick follow-up. I was like,
No.
fast.
Go for it.
Yeah. So that's an important limitation of this approach. But the interesting thing that you see is this protective period, this blue period, where you see negative correlations between vaccination and mortality. It doesn't kick in until the 5th or 6th week, and consistent with what's known with waning immunity, it goes back up after about 6 months. And this period right here, we've been having discussions about what we think it means. I think it might be related to the booster shots. So in these countries, the booster campaign started about 6 months after the initial vaccination campaign. And I think he's been digging into it, and he sees some correlations between the rate of boosters with the rate of the first dose. So that actually could be accounting for this second adverse period right here. And then the second period could be the protective. You know, this is sort of speculative. We're kind of mapping sort of interpretation onto this graph. Yeah, the second period could be the second protective effects that you get from the booster. Could be, yeah. But this is the most important thing that I would take away from this graph is this period here where you see adverse effects in the first 5 or 6 weeks before you see a protective effect.
And the amplitude is sort of very comparable, right? Interesting. I don't know if...
yeah, the amplitude with the percentage. Yeah, I mean, there's, you know, who knows how much whether, you know, temporal autocorrelation, you know, these are very correlated in time.
Okay.
And so I, you know, these aren't independent observations. So it's tough to really make too strong of a comparison,
Yeah,
like a
okay.
quantitative comparison. But I would say qualitatively, this is a really interesting graph. And for me, like when I saw it, or I saw an earlier version of that, I was like, wow, this is really interesting. You know, especially these adverse effects. Can I replicate that in the US data? And so that was where I kind of picked up on his stuff that he was doing. And I wanted to see if I could see a similar effect using similar data in the US. And then the second aim, after I did sort of replicate the effect, the second aim was, okay, the US gives you real units of actual vaccine doses across states, and it gives you actual death counts. So in theory, you could use that data to try to get some data-driven estimate of mortality risk following COVID vaccination. So those were the two main objectives. Excuse me. So the data, this is all publicly available data you can get from the CDC. So this uses 3 spreadsheets. The first one is the number of vaccine doses across states and territories. And the second is it says COVID deaths, but it also gives you total deaths as well as influenza, pneumonia. So you get more different types of deaths. You also get total deaths from the second spreadsheet. And then the third variable, for some of the analyses, I wanted to try to make sure that COVID cases weren't accounting for the effects. So this third spreadsheet was used mainly to look at case rates across states. So the CDC data is not very helpful to work with. It's not very user-friendly. So I've created these tables that they're basically curated versions of the data. And I have them on GitHub. So anybody who wants to try to replicate this or inspect it, they can go to the GitHub, download these tables. All they need to do is just double check that these values match the CDC data, the currently available CDC data. And then they can rerun the analyses. But basically, these tables just have for each state, you have the number of vaccine doses in a previous month, which is this column, and the number of deaths in each state for the current month. That's age stratified. And so you have these counts for year 2020, and then you also have the counts for year 2021. So those are the 3 for a given age group. You're just working with those 3 variables. So the modeling, so in this case, I just took each of those 8 age groups, and for each of 7 months in year 2021, shortly following the vaccination campaign, and we just estimated 56 regression models, 1 for each age group and month. And we're just modeling the number of deaths in year 2021 in that month as a function of the number of deaths in year 2020, plus this effect of vaccination, which is the number of vaccine doses that were administered in that state the previous month. and they're log transformed because the states vary a lot in terms of the death counts and the vaccination rate. So this helps normalize the data.
So,
yeah, go ahead.
If you get a low value for the coefficient associated with the vaccines, it would mean that that's not an important variable to predict deaths. So,
Exactly.
okay.
Yeah. So we're doing inference on this beta 2 term here. That's the term of interest. So we want to see if it's positive, and if it's positive, how positive, and does it deviate significantly from 0? Sorry, the phone's ringing in the background. So the following results are just reporting this beta 2 term, and in this case, we've corrected for multiple comparisons using false discovery rate, and we're only going to show the beta weights that survive that threshold. And before I get to that, I'll show this is an example plot where the states are labeled, and you see, with the exception of a few outliers in this age group, you can see that the vaccination doses in March positively predicted the residual deaths in ages 75 to 84. So there's a positive slope here. And what was interesting, I think, about these outliers is that there was an analysis of VAERS, which suggested, and again, there could be so many explanations for this, but if you just look at VAERS and you separate out the reports of death according to lot number, so each vaccine is part of a batch, and you can actually get that batch number in VAERS. So what they did is they found, or they suggested, and this hasn't been confirmed, it's not been published, it was just part of an article. So if it is true, it would suggest that about 5% of the batches were responsible for almost all of the deaths from the vaccine. If that's true, that suggests that there's some issues with quality control or manufacturing or distribution that's making the vaccines bad. Again, there could be so many different explanations for this, but interestingly, we find, at least for this age group and month, all of these outliers, because I wanted to see, okay, why are there so many outliers? And one potential explanation is that these states, because they're more populated, and there's probably more distribution centers that are, who knows, that are near them, they were less likely to have bad batches sent to them. And then they have, yeah, go ahead.
Oh, sorry. You can wait till you finish.
Okay.
To answer my question.
Yeah. So this table right here is this table here is just showing, it's suggesting that there's a 20-fold difference in the vaccine fatality rate according to state. So these states here have a much lower, a 10 times lower rate of vaccine-induced death than these states up here. So that's, or 5 to 10 times, yeah. So it's not that huge, but it's interesting that these outliers are all on the low end, which could explain why they're not factoring into this relationship, possibly. So if you do this, if you plot, I'm sorry, so you had a question?
Yeah, just a quick one to contextualize a bit. So I guess even removing these outliers, the slope is quite close to being flat, which is expected because I guess the absolute risk from COVID is still not huge.
You mean the vaccination?
Well, the protection that the vaccine gives you reduces your absolute risk of death by a small percentage.
Yeah, and then here, yeah, and then by the same token, the actual risk of death from the vaccine is also small.
Yeah.
So you wouldn't expect these slopes to be huge.
Yeah, but I'm wondering, is there a formulation of this in terms of relative risk? If you sort of normalize out the absolute risk to see, within that regime, could you see like a clearer trend possibly?
Sort of some sort of normalization over
In a way, yeah, in a way it's relative. Yeah,
It's-
so in a way
it's like
you
some
can
background
sort of see,
distribution.
yeah, so in a way those deaths are, yeah, it's your baseline normalization factor. So in a way you're sort of you're looking at any contributions above and beyond the 2020 values. And then, but yeah, but the limitation with this approach is you can't do a relative risk relative. You can't separate people out by vaccination status and compare them directly. We have to infer based on any effects that might be detected between overall vaccination rates and deaths. So in that sense, you can't directly get this relative risk quantity.
I had a question
Yeah,
on your on your
Yeah.
hypothesis of these like these bad batches.
Yeah,
So-
I was in my hypothesis, but yeah.
Oh,
Yeah, the
sorry,
question- yeah.
or the hypothesis
Oh.
you presented, but
Yeah.
So okay, so I don't know, I'm not familiar with all the, like, I guess New York
Mhm.
is NY, but
Mhm.
so that's very populated.
Yeah.
There's a lot of people in New York. So I would assume if there's a lot of people in a state, they probably get more batches of the vaccine.
Mhm.
So I would expect that the places that are the most populated, that get the most vaccine, have a higher chance of getting a bad batch.
Yes.
So I would expect
Oh.
places like New York to
Mhm.
place very high in terms of mortality.
Oh, wait. You would expect it to place higher, not lower.
Yes, because this is my naive understanding.
Yeah.
So if there are more people,
Mhm.
then we need more vaccine to accommodate those people. And if we need more vaccine, there's a higher chance that I get one of these bad batches to come in.
Yeah, but that gets diluted by the number of total batches. So it's a rate. So if you're
Sure, but if the deaths only happen from the bad batches,
Mhm.
shouldn't I just see spikes whenever I get these bad batches in the data?
That I'll have to think about, but what's related
Okay.
to your point, which I didn't get into, is that the same report was showing that these bad batches were distributed to more than 13 states. So a bad batch was more likely to be distributed to many states,
Okay.
whereas the good batches were more likely to be distributed only to a few states, presumably
Okay.
the more populated ones.
So
So
we
I don't know
know-
if that changes. I should have mentioned that in the beginning.
No, okay. So you're saying that almost all states got a bad batch, or most states,
Yeah.
a lot of
Yeah.
states got a bad batch.
Yeah.
And then obviously, if there's more people in the state and you take a rate, you divide by the population, and the rate goes down.
Yeah. So you divide
Okay.
by the number of vaccinated,
Right.
and the rate would go down. Presumably, yeah.
Okay, I understand. I think
Yeah.
I understand the point.
There's so many other factors. Like this could be, the age composition is probably very different, and that could be related. The underreporting. So some states might be less likely to report adverse events than other states. So there's so many things that could account for this. I just thought it was interesting that these outliers were sort of mapped onto the low end.
Well, they're also geographically correlated, right? They're all like
Geographically correlated.
northeastern states, I'm guessing.
Yeah. Mhm. So we don't see these outliers with every age group and month. So it suggests that a variation across time in this potential effect or explanation. But if you make these plots for every age group and for every month, and in this case, the good news is that the hypothesis was confirmed. We did see an adverse effect. The bad news is these are adverse effects. And these are positive correlations between the vaccine doses with the year 2021 deaths after adjusting for year 2020 deaths. So what convinced me that this might reflect the adverse effect is that it matches this age-related temporal pattern that was consistent with the vaccine rollout. So older age groups got the vaccines in the first few months of 2021. That's where you see these significant beta weights for those age groups. And then you see positive significant beta weights in the second half of the year when in the younger age groups, when they started getting more vaccinations. So that is sort of an interesting pattern that fell out of the analysis. There was nothing that I did a priori to sort of affect that. So, and the other point, well, that was the main point, is that these effects seem to suggest that the vaccine is causing the death. Now there's some potential explanation. Someone could say, well, if someone is experiencing a COVID wave and there's lots of death happening, they're more likely to go out and get vaccinated. So who's to say that this doesn't show a relationship where it's a correlation that's caused by the reverse sort of effect, or the reverse causal effect. So that's one reason why I did do another version of this analysis where I just looked at non-COVID death. So the CDC spreadsheets do include, they separate out COVID versus total deaths. So you can do this analysis just with non-COVID death, and you see a similar temporal pattern. The effects are not nearly as strong just because you have fewer observations in the younger age groups, because COVID is rare. COVID deaths are rare. So not as many states. Yeah, go ahead. Harry.
Sorry, I didn't mean to cut you off.
Yeah.
But one thing I thought of, so I don't know if this is the case in the States, but here we often get the argument that because of COVID, certain routine procedures are not being performed because there's not enough space in the hospitals, and here being Canada, sorry, or Quebec specifically, so that people that have, let's say, colon cancer, where we could have prevented that, can't get the proper screening, and so they might die when a COVID wave hits because they just couldn't get the proper screening that they would have got 2 years ago. Is this something that could? So I guess my question is, how can we be sure that we're just not correlating everything to COVID and the adverse effects on the system?
Yeah. So that's why. So I'll show that graph right now. I'll skip through everything else. Yeah. So this is the graph.
Actually, sorry, Spiro. I don't know if we can just go to your the picture that you skipped, maybe for people who aren't as familiar with the regressions. I think it was like an illustration, right? And then we should go back to Perry's
I'll go back to that.
Or in any order you like.
And I'll circle back to Perry. So this graph is basically to give you the intuition behind how these regression slopes, or these fitted lines between vaccine doses, that sort of give you the best fit model between vaccine doses and deaths on the y-axis. This is just basically using the rise over run relationship for that fitted slope to give you an estimate of mortality risk, which is the model estimated deaths, which is this rise amount right here, divided by the number of vaccine doses. So if you traverse the x-axis over a certain amount, that line is going to give you a predicted number of deaths for a given number of vaccine doses that you traverse on the x-axis. So that relationship is what is giving you this mortality risk estimate expressed as a percentage. So the percentage of model predicted deaths divided by the number of vaccine doses.
And this is still a linear relationship, right? You're taking the log of both variables? Okay.
Taking the log of both variables. And so the modeling, this is just to formalize the modeling. So you're just solving for this y hat 1. I'm sorry, you're solving for y hat 2, which is this value here. You want to know, you're given a starting point, what's y hat 2, and you're solving that after you keep everything else constant, and with y hat 2, you're just adjusting your x, in this case, like a 10% increase in vaccine doses. And that's your number of this is this line right here. So it's always controlled in this case as like a 10% increase. And then given a 10% increase, what is this new y that you would expect based on your fitted model? And then you can do that for each month and age group, and then you sum, you average, you sum across all the states. Let me see if I can remember. N is the number of states. So you're taking for each state, you're fitting this relationship for each state, and then you're taking all of the vaccine doses across all those states, and then all of the model predicted deaths, and then for each age group, you're just dividing that and then taking the simple average to get an age-related vaccine fatality rate. So it's an indirect measure. It's really the analysis sort of is, you're not testing vaccinated people directly. You're testing whether there's some latent effect of vaccination that you can detect on death, and then you're taking that model to give you a risk estimate.
So when you report a p-value, is it that you're treating the beta as a random value, a random variable that you're getting multiple, you're getting some statistic on? Okay.
Yeah, and you're just testing that against 0. So this only uses the beta weights that you're confident in are deviation from 0. So the only beta weights that go into this calculation, actually for the average, I used a looser threshold to try to get more. So these represent the average across months, and I'm not showing that in this table, but I used a looser threshold to try to get an average, better estimate. I mean, this could probably be improved. This is a first pass.
And so do you, just a clarification, do you do this, do you repeat this across states to sort of approximate some independent sampling?
So I took each state because the population of each state varies. So I just did this across each state, and then just averaged across all of those states. So took the sums across all states.
And if you did it across all of the US, you should still see a signal, no?
I did it for so the problem, so you mean
just sum all the deaths from all the states and all the vaccines from all the states and see if there's
that's what I do here.
Okay.
Yeah.
Oh, right.
That's what I'm doing here. Yep. Yeah, exactly. Yep. So this is sort of the national average estimate by doing what you just said. So this is the sort of sobering table, is that most of the deaths appear to happen in the older age groups and earlier in the year, and there's a much higher, relatively higher vaccine fatality rate that you get with this approach in the older age groups, which decreases as you get into the younger age groups. So it's about 0.04%, which is like 4 out of every 100,000 in that age group, and increasing it to the higher age groups. And then you can take these model estimated deaths for all of the significant beta weights, you add them all up over that time period, and then you divide it by the total number of doses that were given in that time period, and then you get this estimate, this national average estimate for the mortality risk. So this estimate, you can say, okay, how valid is it? What's the face validity? Does it make sense?
Sorry,
go ahead.
Before I don't mean to, sorry. If you go back to your table, because we're on it, and I think you've highlighted in blue you mentioned the paper as well. So these are, I guess, people that have not been vaccinated.
Yeah.
That seem to be affected adversely by some vaccine they haven't taken.
Yep.
So in the paper, you mentioned that most of these are like people, children under 1 year old. So it could be affected by, I guess, pregnancies and deliveries and all this stuff. Is there a way to, correct me if I'm wrong at any point, but is there a way maybe to get to separate the age group even further? Let's say cut out the less than 1 year olds and see what happens to the 1 to 17 year olds, say?
Yeah. No, I had another discussion where I was thinking that I should do that. Actually, the CDC, they don't do that for you. They give you the under 1 group, and then they give you the 0 to 17. They don't give you a 2 to 17. So the only way you can break it down further is, I have to go back and see. Yeah, go ahead.
You need 0 to 1 and then 1 to 17, right?
Yeah. I mean, that would be the appropriate.
Because then I guess you can eliminate factors like the hospitals are too packed, so we can't do anything.
Yeah, I'll probably redo. I'll probably. That's a good point.
So I guess because it brings me to my earlier point. Maybe I guess it's very difficult to say that the vaccination is causing all these deaths, because everything is correlated right now with COVID, right? Because it's affecting so many things. So maybe like I said, like the hospitals are overrun, so the vaccination just happens to coincide with the hospitals getting a spike in people, being sick people. So things like cancer screenings and I break my leg, get an infection, I can't go to the hospital, and I die or something. Maybe that just correlates somehow with the vaccination rates, which then correlate with the deaths.
You could probably get that data, right? Hospital loads,
which
add that as a variable.
Well, maybe it's I don't know how easy that it is to get in the States. Here it was kind of hard, no? We tried to get that data ourselves in Canada or in Quebec, and it was quite difficult actually to get the hospitalization data.
Yeah. Any sort of if you have a data set that could address that, please shoot it. Send it to me. I've had potential explanation that potentially makes sort of similar to what you're suggesting, is that once people get vaccinated, they potentially engage in more risky behavior because they're out in society more, and maybe they're more prone to accidents or more prone to engaging in behavior that's more lethal.
But that wouldn't explain it for the less than 17-year-olds, right? Or less than 18.
True. Yeah, true. Yeah, exactly right. So the counterfactual to that is that the fact that you see that effect in a less than 1 year old, assuming it's everything's done correctly, then yeah, that would negate that interpretation.
Because I think if you're because the hypothesis you had, I think is potentially valid, right? Like maybe it's just these very young people that are skewing all the results to like pregnancies and stuff like that. But we can just check that, and then we can make sure that that's the hypothesis is valid potentially.
Yeah, we
can falsify the hypothesis, is my point.
So you're just talking about the 0 to 17 age group.
Yeah. So because for me that was shocking, right? That even though they have not been vaccinated, the model still finds that their deaths, their deaths are the vaccination with vaccination rate.
Yeah.
And the hypothesis you present could potentially work.
Yeah.
But we can falsify it quite easily, or we can try to falsify it and see if it holds water by just checking the above 1 year olds.
Yeah.
I don't know if you agree.
I do agree. Yeah, that's actually a good point and something that I should do. And thank you for that.
Cool.
So sorry, we say that 0 to 7
go ahead.
aren't vaccinated because they haven't been approved to take the vaccine.
They weren't approved yet. Yeah, and that's another point. Is I got to check the timeline to see when. Actually, I think the 12. I think the above age 15 actually was approved earlier. So yeah, so some of so I think they're 15 and above was approved earlier. So yeah, that kind of complicates it a little bit.
But I guess you can always just I don't know how much age data you have, but you can always just check like 1 to not approved, and then not approved to 17 or approved to 17.
Yeah.
Get that time period where there's no like people cannot take the vaccine, and just check if deaths are correlated with the vaccination rate.
Yeah, I should dig into that more. That's a good point. All right, so in terms of the overall, this overall estimated here, our estimated VFR. So does it sort of make sense in terms of independent estimates that are based on VAERS? So if you take the CDC reported VFR, use that as the denominator, divide our estimated percentage, it suggests there's a 20-fold underreporting factor for VAERS deaths. So we're missing, VAERS is missing, it's only getting 5% of the total deaths that are actually attributed to the vaccine. And then this is similar to, well, it's actually less because death is the most severe outcome. Another severe outcome such as anaphylaxis, I touched on this earlier in the talk, but these authors here, Rosen, Crawford, and Kirsch, suggested that, or estimated that the VAERS underreporting factor for anaphylaxis specifically is 41. So that's their sort of estimated underreporting factor for anaphylaxis. And the 20 sort of sits in between 0 and 40. So that number, it's not astronomically high. It makes sense. It's believable in this context when you compare it to the VAERS estimates. And then finally, getting back to the whole purpose of this analysis is so that you can compare the benefits versus the risks of the vaccination. Now, if the risks, if the infection was much more lethal, obviously the vaccination would be helpful in most cases. But in the younger age groups, as you'll see here, the infection fatality rate for groups below 50 or 44 seem to be similar orders of magnitude as the estimated vaccine fatality rates, suggesting that the vaccine should be contraindicated for anyone below 50. These numbers are low, but if they're similar between the worst outcome, the same adverse outcome that you get with no treatment versus with treatment, that strongly suggests that the treatment should be avoided. And then I would argue with the above age 50 group, given that the boosters, there's really limited safety data in general, but even more so with the boosters. So I would argue that we should hold off on the boosters. I just don't think, especially with the mandates, I don't think we should be recommending the boosters. Definitely for the younger age groups, but even debatably not for the older age groups, given the lack of data. So that's, yeah, go ahead.
So I don't know what this looks like. I don't know what this looks like in the States, but are there pushes right now to vaccinate children?
Oh yeah, yeah.
Okay. So presumably this number would go up, I guess, if the 0 to 17 are actually taking the vaccine.
Presumably, I mean, the 18 to 29. Yeah, I'd have to think about that. Yeah, so if I were to rerun the analysis in later months when the children are getting more vaccinated, yeah, that's an interesting.
So I guess yeah. Just to make my question a bit more concrete, or to get back onto it, if the hypothesis is that a lot of the deaths due to vaccination for children are for those children that are below 1,
mm-hmm.
That means most of that means that almost no one has died from the vaccine between 1 and 17 years old.
Mm.
But if you start giving them the vaccine, you will have at least 1 death in that age group.
Yeah.
Which should increase the rate.
Yeah.
That's my naive thinking about this.
So good. Yeah.
So I'm guessing. So what I'm saying is, maybe this is even more, for children it might be even more dangerous because you have the well, dangerous. I don't know, more risky. Let's say.
Yeah. And I've been meaning, that's on my docket. I've been pulled in other directions, but yeah, I've been meaning to update the analysis through January. When during the time period when the children are being vaccinated.
Also interesting because now that Omicron is out and it's supposed to be even less deadly.
You use the English pronunciation.
Yeah,
at first.
He corrected himself though.
I corrected myself.
Like we're like all yeah.
But presumably that which is even poses even less risk than the earlier variants.
Yep.
That would also probably affect the numbers, right? In the positive direction.
Yeah. So
yeah, it would be interesting to actually see this for like now this season, this wave.
And this was an earlier paper, so this is probably when the variants were a little bit more lethal. And we know that Omicron is less lethal. So that even tips the ratio even more to not favor the vaccine. So that's it. Yeah. So that's I can answer more questions. We can go to the paper if we want to. If there's any other sections.
No, thanks so much for that. I have maybe this is something a little bit orthogonal, but is there like a clinically verified adverse effects that are known right now that are widely accepted that could lead to death?
So I'm not a cardiologist.
Yeah.
I think the myocarditis could. I'm guessing here. I don't know what the mortality risk is. I
guess I'm just trying to get at if there is a confirmed effect, then we know that that there's something that we can measure, I guess.
Yeah.
Once at least one case is actually confirmed, then it must be happening more broadly.
Yeah. So there's been case reports of autopsies, even early on, where they've confirmed these effects, and it was mostly, I didn't read those specific reports, but from what I've read, the effects have mostly to do with immunothrombotic effects of the S protein interacting with the immune system and the coagulation system in an adverse way. So that's why they say one thing that you can do to test for evidence of microclotting is to do like a D-dimer test. And that would suggest, following the vaccination to see if there's any microclotting. So I would say that's the most, aside from the pericarditis, I would say that's the most, the second most important sort of risk. That's, it's important to measure and quantify. Yeah.
Do you know if they've seen any of these effects in the vaccination trials?
So what I've read, so there's some witnesses, I don't know about witnesses, but yeah, people who were in the trial who had adverse events and they weren't able to even report it or get much of a response from, I think it was Pfizer in that case. I don't want to make it up, but yeah, I could send you some links of people who suffered vaccine injury and they don't think they were included in the write-ups. So I haven't confirmed that. But if you looked, so I did read the Moderna clinical trial, and I can say that they have a sentence in there where they say the regulatory agencies only required a median follow-up of 60 days, I think it was 60 days.
Meaning the median between all the times they follow up is 60 days between all patients?
Yes.
Okay.
So they only had a required median. So they didn't even require So there was an active surveillance for 7 weeks. And then for 7 days. And then after 7 days, they only report things that the patient reports it, but up to 30 days. And then after, hold on. I got to reread the paper. But there was a window after which they would not accept adverse events. And I think that was 30 days. So after 30 days, they did not include reports of adverse events beyond 30 days in their assessment window. They only included it if it was medically attended. So if there's a medically attended event, this is worth another discussion to kind of dig back into that paper. But I think the main thing that caught my eye was this requirement for a median follow-up period. Because mathematically, you could have 51% of your patients have 0 follow-up, and then most of the other half of patients have greater than 60 or whatever. So when you're dealing with the median, mathematically, I forget the actual number. I think I calculated based on my reading of the main text. My point is that the follow-up and the sort of tracking these adverse events was not done as rigorously or as as it should have been. And go ahead.
But these 30 days still fall in that window, that first window that you pointed out, which was 5 or 6 weeks.
True. Yeah. So
presumably they should have been able to see some. I don't know. I don't even know how many people were in the trials, but presumably they should have. Well, okay. Again, it depends, because we're talking about numbers, absolute numbers that are like 4 out of 100,000, and I'm guessing the trials are, I don't know, a couple thousand people, maybe tens of thousands.
That's the other thing, is that trials are underpowered to detect.
Sure.
Yeah.
Okay. So it's not. Yeah. Okay, that makes sense.
Yeah.
But they did see a signal for COVID. Okay. Yes. It's a very difficult problem, I guess.
Yeah. Yeah.
I have maybe a bit of a recap question, but would you be able to go over how this study controls for the confounding variable, at least of COVID cases?
Yes. So for that one, so there's 2 ways. One way, which I already sort of touched on, which was to use the outcome variable of non-COVID deaths, and then the second way was to include. And so in this regression model, we reran the regressions, but we included an additional term for cases in the previous month. So we adjusted for case rates, differences in case rates across the states. And then those results were pretty similar.
Okay, and then presumably you could add again a factor for hospital loads and a factor for, I don't know, number of bungee jumping reservations.
If I have the data, I can easily include it and rerun the regressions and see if they affect the results. But the hospital load. So you're saying if there was a higher hospital load that prevented people from seeking treatment, that could, so that
we could rule it out potentially.
Yeah.
Potentially we could rule out that is causing all these deaths, right?
Yeah. So I think the limiting factor there would be the data. If we had statewide data that quantified the hospital loads. I mean, the COVID cases, in a way, sort of indirectly indexes that. If we have higher COVID cases. But
actually, that might even be that might be perfect now.
Yeah,
that will correlate almost perfectly.
I mean, they were very correlated.
Maybe with some lag, I don't know.
The cases with deaths, especially COVID deaths. Yeah, when you look at.
But I think they even correlate with hospitalizations, right? And like hospital resources available.
Oh yeah.
They probably correlate with all that stuff.
Yeah. So if you have any other thoughts, please send me. Please follow up, and this is still a work in progress. So.
Cool. And is
Yep.
is this currently submitted anywhere or?
No, I just got my latest rejection a few days ago. So
Okay.
I'll have to, it's so annoying because you have to reformat it. I mean, some
Yeah.
journals let you just upload a,
We've been there.
paper your whole day.
We've been there.
Yeah. Yeah.
Would you be able to comment a little bit on what kind of feedback you've been getting
Sure.
and how it's actually made the paper evolve? I know you touched on it a bit, but it'd be cool.
Yeah, I would say.
Or maybe before that, just touch upon the situation. So I'm guessing you've attempted to publish this multiple times, and you've gotten constructive or otherwise feedback about why it should not it does not meet qualifications of certain journals. Is that fair?
Yeah, I would say
Okay.
it's been desk rejected by all the editors so far. Hasn't been sent out for peer review. And I would say, some, my cover letter asked for specific reasons for the rejection in order to improve the manuscript and to get their suggestions for how can I get this published in a reputable journal. So I think it's important to get it validated. Not that I'm assuming everything's correct, but at least to get it peer reviewed. Because if it is true, I would think that this should get, more studies like this should get more attention and get published. I would say some journals just gave me the pat, sort of like this doesn't fit into our focus. We have so many COVID submissions, we just can't find the space for it. Other journals tried a little harder and gave me some sort of feedback on the actual substance. One of them did sort of say, well, how do we know these reflect the causal effect? Of these regressions, how can you infer causality? So I added a whole section on the reasons for why that would be the simplest interpretation. So that improved the manuscript.
You think we could pull that up quickly and maybe have a look? I know
Sure.
It's like a sort of bulleted list, right? Be interesting to
the
about
reasons
that.
for the causal. Yeah. Mhm.
Hey, it's me.
Yeah, that's so let me pull up the paper.
I think you're the first person I messaged on ResearchGate.
Yeah, I rarely use that function, but that's how I reached out to Hervé, was through ResearchGate, using the messaging.
Yeah, I wish more people used it, including myself.
Maybe they should sponsor us.
What's
Oh,
that?
yeah.
Maybe they should sponsor our discussion.
Yeah, research.
This discussion is brought to you by ResearchGate.
Yeah, right. So let's see here. Let's get to the paper.
And actually, while that loads, I had another quick question.
Sure. Yeah.
Was it surprising that there was also a positive effect in the older age group? I mean, usually what you hear is older people aren't reacting as strongly to the vaccine.
Yeah, actually, that was the assumption that I had for a little while when I was first getting into this, is that the the immune response, because it's so robust in the younger age groups, that was driving the stronger adverse reactions. And I don't know how age, I'm not a cardiovascular scientist, but I haven't quite looked at why the risk for myocarditis would be higher in the younger age groups. And so yeah, it was somewhat surprising when I saw the huge bulk of the effects were in the older age group. From a statistical point of view, it wasn't as surprising because I was aware of other reports that had come out about older people, a certain percentage, or an alarmingly high percentage of them passing away after the vaccination. So there were concerns about that early on, and some estimates of death. I think there's one actual lawsuit where they claim like 45,000 of these people in the older age group under Medicare, were caused by the vaccine. And so sort of that number, so it made sense in terms of comparing the numbers that I was seeing with these numbers that other people were claiming. But in terms of the mechanism, that I'd have to, I'm sure it's related to, standard age related processes that, if people are stressed or or if they have other sort of factors that have piled up.
Well, I think you
comorbidities.
mentioned in the paper that there seems to be a known effect. I don't know to what degree it's confirmed that after the vaccination, there's an increased temporary susceptibility to COVID itself.
Yeah.
So if the older age group is also already more susceptible to COVID.
Yes.
Then...
Yeah.
Okay.
That's another explanation. Yeah. So lots of variables and lots of all right, let's see if we can download this. All right, so we wanted to go to the supplement.
The causal argument. Yeah.
So this is what I wrote up after I peeled one of the journal families. And it was like a journal family that had like 20 different journals. So it wasn't, and they just kind of rejected the paper from all of them at once pretty fast. And then they have an appeal process. So I appealed, and they have like an in-house statistician. And I said, okay, look, if you have an in-house statistician, why not take the data? It would take them like a day or two to confirm these results. I would think that you'd want to spend a little more time trying to validate this. And to their credit, they did kind of consider it, and then they got back with a little bit more constructive feedback. And in that case, their feedback was this correlation versus causation.
And I would, this type of study looks a lot like dozens or maybe hundreds of other studies that study excess death from coronavirus, right? Kind of, it's the same hypothesis, right? You should see some population level shift in mortality just from a different dependent variable, I guess.
Yeah.
So, sorry, independent variable. Is the methodology comparable enough that they wouldn't be thinking, this is completely out of the blue? Why would you be even doing this?
Yeah. So apparently this type of approach, I think it's called technically like an ecological study design, where you take, regional estimates and you correlate in some variable, and you correlate them across regions, the same estimates for other regions. So there's a field that tends to do this type of analysis, and even in mental health, which is my main, neuroinformatics. I've read a lot of papers that do some type of version of that analysis where you're cross-correlating these variables across states. So I've seen it in different fields. So I don't think it's that far out. But yeah, they didn't mention, well, one of them mentioned that the methods weren't clear, that they weren't presented in a way that would allow someone else to replicate them. So I did change the manuscript to try to, added subject headings and tried to make it more clear. And, I got some good feedback from someone who gave it a close read. So in terms of the section that you were referencing, I wouldn't say this is the strongest reason, but, the fact that we're looking at vaccinations before the death. So there is this temporal precedence that would suggest it's not the vaccinations that's causing the death. There's going to be correlations, like autocorrelations in the time series, but which would potentially sort of not make that temporal precedence matter so much. But there is that factor. And that's sort of the basis of these time series analyses that use temporal precedence to infer causality, like Granger, even though that's not what we applied here. The second is that these estimates are very similar to estimates that you get just using VAERS and credible assumptions about the VAERS underreporting bias. So these other authors that I cite here used the underreporting factor for anaphylaxis based on that controlled study that found that rate of 2.5 per 10,000, which is 41, if you remember that underreporting factor. And they just multiplied that by a percentage of self-reported or provider-reported deaths that were definitively attributed to vaccination. So there was a pathologist out in Germany who actually estimated, who did a lot of these autopsies. And I think he gave some estimate, if I remember correctly, like 60%, he said, of the deaths could be definitively linked with the vaccine. So if you take that estimate, 60%, multiply it by the estimated underreporting factor, 40, and then you multiply that by the actual number of deaths in VAERS at the time, which was, I think, like 10,000, then you get estimates around 160,000, 170,000 for the same time period. And the fact that this analysis, which is completely independent, uses completely independent data, sort of arrives at a similar estimate, suggests that third point sort of suggests, okay, if it's not the vaccine causing the death, what else could it be? Like, what are the other potential factors? And I asked them, what else could it be? I'll try to control for it or adjust for it. They didn't get back to my email. But, like we discussed before, COVID cases or the COVID waves could be a major confounder. And so I tried to control for that in ways that I already described. So that's what this section explains. What else did I list? Hopefully I didn't put everything but the kitchen sink in here. Okay, for existing. Yeah, so I noted that, and I cited a review piece that I wrote where I critically reviewed previous vaccine safety assessments that were included as part of the clinical trials and noted some of the limitations and issues. For example, the requirement of a median follow-up time across patients. At the very worst, at the very least, it created an ambiguity in the reader about how much follow-up period did each person get. So it was unclear. And yeah, that's not the most rigorous requirement. If you're going to regulate a new product, you want everybody to get the same follow-up and make it as long as possible, and make it as active, not just passive, as possible.
I wonder if
yeah.
if there's a trade-off there. If you make it too long, maybe now you start getting false positives, or would they just say, let's just keep them and at least know about them, worry about them later? Or if there's some reason for that narrow time window, I'd be curious.
Yeah. The cynical interpretation is that you're lessening your likelihood of detecting adverse effects, which you don't want if you're a drug company that's financing most of the research. There's going to be some potential conflict of interest, and that might affect the data and its interpretation. And actually, I think it was like a 2005 editorial in, I think it was PLOS Medicine or PLOS. Back in 2005, it was a former editor of New England Journal of Medicine who was basically saying, yeah, a lot of these clinical trials that come out, these journals a lot of these journals have become like avenues for advertisement for these pharma companies, and the focus is not so much on the science. So unfortunately, that tends to influence the editor's decisions about what papers to publish, and then how rigorous of a peer review might go through.
Especially, I think, since they often don't make the data accessible, right?
Yeah.
If you're going to have a
Oftentimes.
conflict of interest, at least make your data verifiable, you know?
Yeah. So there's a lot of problems with sort of the old way. I would cause it, I would say it's the old way of science. I was trained, or there's a lot of initiatives for making data openly available, increasing transparency, and that doesn't seem to have caught on with other fields. So the fifth point is, these sort of estimates comport with the volume and nature of personal experiences of vaccine adverse events that have been submitted. For example, the FDA, whenever they have a meeting to approve the vaccine for a certain age group or a booster, they actually online, anybody can submit a public comment that they want the committee to take into account before they make their decision. And in this case, in the paper, I could go to it, why not? I think this one, for example, the one on October 26th, you can see, 130,000 comments where people posted their opinion about whether the vaccine should be recommended. So this one's not that informative, but a lot of these comments were about personal experiences of adverse events. These are logical arguments. So actually, I'd have to.
So this would be some other way,
logical.
like this would be some other method outside of VAERS for somebody to say something?
Yeah. So earlier, when I looked through these comments before, now I see, earlier when it was only at like 100,000, I saw a lot of comments of people describing, a person that they know had a really severe reaction, or someone that they knew in their extended family passed away shortly after. So that was the nature of the comments. Now, it's not, I can't pull up these comments in real time.
It's annoying that they make you click on them to
Yeah. They could have made this easier, but what was some of these other links? I gotta click back. There was another link, which was a Facebook post. It was a news organization in Michigan, and they were looking for stories of COVID deaths in people that weren't vaccinated. So they wanted to highlight, did you lose a loved one who didn't get vaccinated to COVID? And the responses to that were very interesting. It's this one. I can't click on it. Oh, this is annoying. The hyperlink's not working.
It's okay.
But anyways, I'll just describe it.
Yeah. You can send it over and we'll post it.
Yeah, I can send it. I gotta fix that hyperlink. That link was very interesting because they got a lot of people responding with similar stories. So you can see there's some links where you can actually kind of get a sense of the type of personal sort of testimonies about these adverse reactions that sort of line up. It sort of gives like a real world sense of that these estimates aren't totally wrong. And then there's two websites here that are like meant to give opportunity for vaccine injured people to describe their experience. These are a little bit less quantitative, although this website, you can
DuckDuckGo, well done.
What's that? Yeah, yeah. Took me a while to transition. So yeah, so if you click here and you can read through, in this case, it's, yeah, I guess over 500. I mean, this gives you more of a sense of the type of reactions that typically happen. Yeah, so yeah, each, people write in their experience, and you can browse through this. So yeah, that's the reason I included these links, because you won't hear about it right now in the climate that we're in. It's most people won't come across these types of links.
Well, it's interesting
yeah.
to think about it from an academic or a scientific point of view, right? Like when I saw that, the knee-jerk reaction, if you're doing researches, it's anecdotal. Those are anecdotal, pieces of evidence. I'm not going to listen, but I think in the setting that we're in, where decisions are being made with a lot of uncertainty, maybe it's important to sort of keep an ear out to that kind of thing, right? It could be a kind of hint, at least, or some that kind of evidence becomes important in these kinds of settings.
Like in terms of like a real world safety signal.
Yeah. Obviously, we can't say that this is empirical evidence, but you have to start with something, I guess.
Yeah, I mean, because oftentimes, even no matter how rational we are, our worldview is kind of shaped also by our personal experience and these anecdotes, I think. I personally had one of my parents' friends. I didn't really think this was real until one of my parents' friends came down with acute leukemia shortly following the vaccination. And that, to me, and I've started reading other reports of a similar type of occurrence. So yeah, so that changed sort of my whole, that's sort of what got me to think, yeah, this is a real effect, and
Would you say that the majority of the criticism you've gotten has been about this causal relationship?
I would say that was the most substantive criticism.
And I guess the follow-up to that, like, have you considered maybe avoiding that language, say, and just posting this as like factually we have a correlation between vaccination, like there's a mathematical correlation between vaccination and deaths. Maybe this is nothing, but maybe we should spend some resources in trying to understand this better, and like a sort of call to researchers to try to figure out if it's actually causal.
Yeah, that's exactly some feedback that I got before from someone who really closely read the manuscript. And so I did change like the last line of the abstract to say, to try to just make it more data based. And
because I mean, if you avoid language of causation, I think like it's a valid mathematical study of data. And then there's no reason to reject it from anything, right?
Yeah. So hopefully
that's. But of course, there's also your personal feeling about the situation, right? Like the.
Yeah, I mean, if I'm going to put my career out, if I'm going to put my, in a lot of ways, I'd have to. I really needed to convince myself and really believe it. Otherwise, I don't think anybody would want to put this paper out. So I had to really think, it took me time to kind of sit with it. And until I really was certain that, I kind of had to really believe it before I could put it out in this case. I couldn't be that neutral given sort of the nature of the claims in this climate. Normally I would agree. but in this case, I kind of had to convince myself. And that's why now I'm presenting it, you know, in a way I want to be wrong. So I'm trying to present it and get it out there, also to get meaningful pushback and criticism about the methods, the interpretation. So that's one reason why I like to present it.
I think the point about under one of the points of causality was what else could be explaining this, you know? Do you think that that's something that could benefit from a very deep analysis, or you think it's been, you know, that we've gone as far as we can with that? Because if you really say, look, it's very clear that I've gone through every possible confounder that I can think of, you can really, that can be, I think, a pretty strong point.
Yeah, it could be. That could be a strong point. I mean, if a paper is going to make publication, if a journal is going to make its publication contingent on doing an extra analysis, I'll just do it if it's feasible, and if it's not an unreasonable request. So I'll usually bend over backwards to kind of do that additional, you know, whatever the reviewer requests. But yeah, in my view, I think it's I've made a fairly strong case. You know, people have raised other possible explanations, but we'd really need the data to really test those possibilities.
Great. So I think we should wrap it up. That's 2 hours. Those were very fascinating.
Thank you so much.
Thank you so much. Actually, I don't know if you would mind if we do like a 30 to 1 minute recap of the main findings, and that way we can have a strong close.
Sure. Yeah. So I can sort of show the abstract in the background, even though it's kind of wordy. But yeah, the main finding is using this European data set of vaccination rates and mortality across countries. You can observe this pattern where there's a negative relationship between vaccination and mortality from 6 to 20 weeks post-injection, but you also see positive correlation between vaccination and mortality. And that effect is replicated by looking at short-term correlations between vaccination and death counts in the US across states. And the US data allowed us to actually estimate mortality risk as a function of this rise over run relationship and the fitted regression slopes. So for each age group, we derive an estimated vaccine-induced death rate, which starts around 0.004% in the younger ages and increases to 0.06% in the older ages. And then we can derive an estimated US national average VFR, or vaccine fatality rate, compare that to the CDC reported rate, and we estimate that the VAERS deaths are unreported by a factor of 20 by doing that comparison. And finally, by comparing our estimated rates of vaccine-induced death with the infection fatality rate of COVID, suggests that no treatment is a more favorable option in age groups, especially 50 and younger.
Great. Yeah. So thanks a lot for coming on and sharing. Carlos, I don't know if you have anything to add.
No, just thank you so much.
I thought Carlos, you know, it was great, and we should anytime you have another paper out that you want to discuss, let us know.
Yeah, thank you, and let's be in touch.
Absolutely.
And,
Good luck.
It's great to meet you.